Hi guys, today is going to be the online lecture of 17.5 through 17.7. So we'll be starting with 17.5. This is all about the female reproductive system and some of the functions and organs that are located here. So we're going to start off by talking about some of the functions of the female reproductive system. So first, it is going to be to produce the female sex hormones. Also, this system is going to produce the secondary oocytes, which are just some of the very early stages of eggs. Also, the system is going to transport secondary oocytes to site where they are going to unite with the sperm. That would be fertilization, which is the very first step in a pregnancy. Also to provide the environment for development of the embryo and fetus, so create an environment that a baby can develop. And then also the system is going to be actively involved in the birthing process. So now we'll be talking about some of the structures that are present in the female reproductive system. So first is the paired ovaries, which means there are two of them. There's one on each side of the uterus, so a right and a left. These are going to produce the female sex hormones as well as the secondary oocytes. Then there's going to be paired uterine tubes, which again means we have two, one on each side. These are sometimes also referred to as the fallopian tubes, and these are going to be what transports the oocytes to the uterus. Next, we have the uterus. The uterus is going to be where development of the fetus occurs. Next is the vagina and the external genitalia. These are going to be the female sexual intercourse organs as well as the birthing canal. So the female reproductive tract, remember tract means a pathway, is going to be the uterine tubes, the uterus, and then the vagina. This again is going to be what carries the oocytes and eventually the baby into development and then eventually out of the body. So starting by talking about the ovaries. So the ovaries are located near the upper side walls of the pelvic cavity. Again, we have one on each side of the uterus. These are the same size and shape as almonds, and they're going to be supported by ligaments. Some more about their structure. So first, they're going to have an outer surface that is covered by the ovarian mesothelium. This is just a layer of tissue. Under the mesothelium are going to be the ovarian follicles. The follicles is going to consist of an oocyte, or again, a developing egg that is enveloped by some supporting cells. And then lastly is going to be the inner region that is going to be made up of areolar connective tissue that's going to have all of the nerves and blood vessels that are going to nourish the ovaries. This picture here just shows a microscopic view of an ovary. So we are looking at all of this structure right here, which is going to be all of that almond-shaped organ. You see all of these different follicles inside. We have the primordial, secondary, primary, tertiary, mature. So all of these follicles are developing throughout the uterus, and eventually the goal is that they will secrete a mature egg out into the fallopian tube so that it can be fertilized and eventually turn into a baby. So oogenesis, similar to spermatogenesis, is going to be the process of producing ova, which is a mature egg. So ova is going to be plural for eggs, and then singular, you'll hear it called an ovum. So like I said, this is going to be similar to spermatogenesis, but with just a few exceptions. Oogenesis is tied very closely to the ovarian cycle, which we'll talk about towards the end of this lecture. And then by the 5th month of fetal development, the ovaries are going to contain several million oogonia with 46 chromosomes. So these are going to be what eventually develops into the oocytes. And again, this is saying that females are born with all of the eggs that they're going to have for their entire life. They are already present at birth. So these steps of oogenesis, so again, most of the oogonia are going to mature into primary oocytes, and that is going to be prior to birth, and I would highlight that sentence right there. So again, that is just saying that females are born with all of the eggs that they are going to have for the rest of their life. Each of those is going to be surrounded by a single layer of follicular epithelial cells, and that altogether is going to form a primordial ovarian follicle. This is just the first step in forming that follicle, and again, eventually the goal is that the egg will be released from the follicle and out into the fallopian tube so that it can be fertilized. So females are born with their total number of primary oocytes. It's usually about 2 million. So again, once all of your eggs are gone, you have no more. This is why it's a lot harder to get pregnant as the female's age starts to increase. So no oogonia are going to exist at birth because that is what has then matured into our primary oocytes. So the oogonia are gone, and now we have primary oocytes, which are just a more mature version. So beginning at puberty, we have a few primordial follicles that are going to be activated monthly, and they'll need about 1 year to mature, which will be your first blank on this slide. So after maturation, one primary oocyte, which again is an immature egg, will complete meiosis 1 each month. Prior to meiosis 1, the chromosomes in the primary oocyte will replicate, again, similar to spermatogenesis. And in metaphase of meiosis 1, those homologous pairs will line up and we'll have random alignment and crossover that will occur, and that will give us genetic diversity. So at the end of meiosis 1, we have a primary oocyte that is divided now into 2 dissimilar cells, and they each have 23 chromosomes. So that is the whole purpose of meiosis, is that we end up with half of the amount of cells that we started with. So what's going to happen with these 2 dissimilar cells? You're going to have one is going to be your polar body. So in this parentheses, I want you to write no function. So polar bodies don't have any function. They just are kind of a dumping site for that second set of chromosomes, and they are formed due to unequal distribution of cytoplasm in meiosis, and I would write that down. So again, the polar body is formed due to unequal distribution of cytoplasm in meiosis. And then the second cell is going to be the secondary oocyte. This is going to have nearly all of the cytoplasm that is needed in order to become a mature egg. So both of these are going to be the result of your primary oocyte, and your secondary oocyte is going to be what's released at ovulation, which we'll talk about in just a few minutes. I would highlight and star this slide. You'll want to know what happens at this stage and the 2 types of cells that your primary oocyte divides into. So our secondary oocyte, like I said, is then going to be released from the ovary at ovulation, and I would highlight that statement. So you do want to know that it is your secondary oocyte that is released at ovulation. And then meiosis 2 is only going to occur if the secondary oocyte has been penetrated by a sperm or has been fertilized. That is the only time when we are going to have meiosis 2. So meiosis 2 is also going to yield 2 dissimilar cells, each with 23 chromosomes. Again, we get a polar body, which again has no function and is just a dumping site for extra chromosomes. And then we have the ovum, and the ovum is going to have all of the cytoplasm, and now that that is our mature egg that has been fertilized and is ready to grow into a baby. So it's the fusion of the ovum nucleus and the sperm nucleus that are going to form a zygote, and the zygote is the first cell of the pre-embryo, so it is the first cell of the baby. So this picture here is just showing where we are, or the process of oogenesis. So we are starting with our primary oocyte right here. So that is step 1. Our primary oocyte is going to undergo meiosis 1. And our product of meiosis 1 is a secondary oocyte and a polar body, which is right down here. So remember, the polar body is eventually just going to disintegrate. It really has no function other than it just being a dumping site for extra chromosomes. So our secondary oocyte, again, is what's released at ovulation. here it is showing being penetrated with a sperm, which is fertilization. Then this cell is going to undergo meiosis II. And then from meiosis II, we get the zygote, which is the very first cells of the baby. And then we also get that second polar body that is eventually going to disintegrate. So then talking about our uterine tubes, like I said, they're also called fallopian tubes. So each is going to extend laterally from the upper side of the uterus to an ovary. The functions of the uterine tube are going to be to receive and transport the secondary oocyte. So it's getting that secondary oocyte from the ovary and bringing it down into the uterus. The uterine tube is where fertilization is going to take place. So it's the site of fertilization. And then it's going to transport that pre-embryo if fertilization occurs, and then it's going to bring it to the uterus so that it can be implanted in the uterine lining so that it can continue to grow and develop. So then we also have something called an infundibulum. This is just a funnel shaped and it's on the lateral ends of the uterine tube. This is going to partially envelop the ovary. So it does not fully connect to it. It does not fully cover up the ovary, but it's just going to kind of open up to the ovary so that way we have that opening for the egg to pass through. It's also going to possess something called fimbriae. So fimbriae are finger-like projections or processes, and they are going to sweep the surface of the ovary as the egg is coming out. These fimbriae are going to kind of sweep that egg into the tube so that way we can have fertilization and implantation. And I would highlight what the fimbriae are. And the inner lining is going to consist of simple ciliated columnar epithelium, and these cilia are going to kind of beat and create a current that's going to draw that immature egg, that secondary oocyte, into the infundibulum, and then cilia together with peristalsis are going to move that oocyte to the uterus again so it can be implanted and grow into a baby. So this picture right here, again, is just going to show some of these structures. So your infundibulum is right here, and it's just going to be this enlarged end of the uterus, or sorry, the uterine tubes. The fimbriae are these little finger-like projections right here, and again, as this egg is coming out of the ovary and into the uterine tubes, these fimbriae and then again these cilia are going to kind of move, and that's going to allow this egg, it's going to pull this egg in, and then the egg can eventually go down the tube and into the uterus where it will hopefully implant on the uterine wall. So the uterus is located behind the urinary bladder in the pelvic cavity. It's located above the vagina and it is bent forward over the urinary bladder. It's a hollow organ with thick muscular walls, and it's going to provide an environment, an appropriate internal environment, so environment is your last blank, that will allow the embryo or fetus to develop and grow. So this right here is going to be your primary function of the uterus. It's just going to be to create this environment to allow the baby to grow. So the uterus is going to have three major regions. It's going to have a fundus, a body, and the cervix. So the fundus is this section right here. So it is the most superior portion of the uterus. It is the upper rounded region. The body is going to be the middle region, and it is just enlarged. It's going to be the biggest area. And then the cervix is down here, and it is going to be the part of the uterus that meets with the vagina or protrudes into the vagina. And I would write that down and highlight it. You'll definitely want to know what your cervix is. So the wall of the uterus is going to be composed of three layers. So it's made up of the endometrium, myometrium, and parametrium. So remember that endo means inner. So this is going to be the inner mucosal layer. The myometrium, myo means muscle. So this is the middle muscular layer, and I would highlight that one. And then perimetrium, peri means around, so it is going to wrap around the uterus. It is going to be the outer serous layer. And then we have the vagina or the vaginal canal. This is going to be a collapsible tube that extends from the uterus to the external environment. It's located behind the urethra and in front of the rectum. Some of the functions are that it's going to be your copulatory organ, which just means it is the organ for female sexual intercourse. It's also going to be the birth canal, so that is your second function up there. It acts as the birth canal for a baby passing through. The wall of the vagina is going to have 3 layers. It has an inner mucosa with stratified squamous epithelium, a middle layer of smooth muscle, and then an outer layer of dense irregular connective tissue. So now moving on to the external genitalia. So the female external genitalia is also often referred to as the vulva. So this is going to surround the orifices of the urethra and the vagina. So remember that orifices just means opening. The perineum is going to be the area between the mons pubis and the anus. So it's pretty much everything from the front to the back. It's everything kind of down in that area. However, the obstetrical perineum is just going to be between the vaginal orifice or the vaginal opening and the anus. Why it is just that area and why it's called that. So obstetrics is just talking about birthing of a baby. It's that practice of medicine that births babies. So that is talking about that area between the vagina and the anus. Why it's called the obstetrical perineum is this is the tissue that is often torn during childbirth. So that's the area that they are most concerned about because that's the area that is most often torn. So this picture here is just going to kind of show you all of these different areas that we're going to be talking about. So again, the mons pubis is up at the front, the anus is at the back, and so everything in that area is referred to as the perineum. So the labia majora, this is going to be the paired longitudinal folds of hair-covered skin that's covering adipose and smooth muscle. So this pretty much just encases all of the other reproductive structures of the female. It's going to be the most outer layer. So the folds join in the front at what we call the mons pubis. So that is just a rounded cushion of adipose tissue. And then it's going to be formed from the same embryonic tissue as the scrotum is in males. Then the labia minora, so this is a paired thinner longitudinal folds. They're going to be more medial to the labia majora, so they're closer in. And then they join at the front to form a hood-like covering over the clitoris. This is going to be where most of the sensory receptors are located in the female. And then it's going to join the labia majora in the posterior section or the back of the reproductive area of the female. So then we have the vestibule. So the vestibule is going to be the narrow space that is between the labia minora. This is going to be where the urethra is going to open in the front portion, whereas the vagina is going to open in the back portion. And then the bulbs of the vestibule are going to be composed of corpus spongiosum. So it's very similar to the erectile tissues as the male. This is located beneath the labia minora, surrounding the beginning of the vagina, and then it's going to be engorged with blood during the female sexual response, which we'll talk about in the next section. The vestibular glands, these are going to lie behind the bulbs on each side of the vaginal orifice, and these are going to release secretions into the vestibule, which are going to act as a source of lubrication. And then the clitoris, like we've kind of already talked about, this is formed of 2 columns of corpora cavernosa near the pubis, or it's at the front of the genitalia. The glans of the clitoris is just a union of those 2 columns. It's located behind the mons pubis where the labia minora meet, and it is abundant in sensory receptors, and it is involved in the female sexual response. So now moving on to the female sexual response is what this section will talk about. So for the females, in absence of sexual stimulation, the erectile tissues of the bulb of the vestibule and clitoris are going going to only have a small amount of blood. So this overall, you'll notice, is going to be very similar to the male sexual response, just obviously with different structures. So in the presence of sexual stimulation, there will be parasympathetic action potentials that are going to lead to erection of the clitoris, and it's going to have a very similar mechanism as in males, is that all of the genitalia is going to become engorged with blood, and I would write that down, that the erection in this case is caused by engorgement with blood, as a very similar mechanism as it is in males. So the parasympathetic action potentials are also going to cause enlargement of the vaginal mucosa and breast, as well as erection of the nipples. I would highlight that statement as well. And then these are going to, the parasympathetic action potentials are also going to stimulate the vestibular gland to release secretions, which are going to lubricate the vestibule. And then, similar to males, the sexual response is going to culminate in orgasm. Orgasm is caused by sympathetic action potentials, and so I would write that down, that it is caused by sympathetic action potentials, not parasympathetic, which just gets everything ready for the sexual response. So then, like I said, sympathetic action potentials and prostaglandins in semen will trigger reverse peristalsis in the pelvic floor, in those muscles, as well as the uterine wall and uterine tubes. So reverse peristalsis is just meaning instead of a wave-like movement to get things out of the body, now we are having a wave-like movement to kind of encourage the semen to move further into the body. The purpose of that is that it's going to aid in moving sperm through the uterus into those uterine tubes, because the whole goal of this whole entire system is that we are going to have fertilization and pregnancy, because the reproductive system is all about trying to make a baby. All right, so then moving on to the last section we're going to talk about. So this is talking about hormonal control of reproduction in females. So the ovaries are going to produce two major groups of female hormones. That's going to be your estrogens and progesterone. So your estrogens are going to be your primary female sex hormone, and they are produced primarily by the ovaries. So they're produced by ovarian follicles that are exposed to FSH, or follicular stimulating hormone. Your estrogens are going to stimulate maturation of female sex organs and also stimulate development and maintenance of the female secondary sex characteristics. So this list here is all of your female secondary sex characteristics, which are all things that go along with puberty but are not actually involved in reproduction. So development of the mammary glands and breast for breastfeeding. Females are going to have a broad pelvis. That's your blanks there, broad pelvis. They're going to have an increased subcutaneous tissue deposition, which is going to give females bigger breasts, bigger thighs, butt, all of that. So it pretty much is what gives females their curves, is this increased subcutaneous tissue deposits. Also increased blood supply to the skin, and then lastly, development of axillary and pubic hair, which is going to be due to androgens. So it's a very small amount of male sex hormones that's going to be produced by the adrenal glands. And then your next hormone is progesterone. So this is produced by the corpus luteum. So the corpus luteum is just the ovarian follicle that is remaining after ovulation has occurred. So after that secondary oocyte has been released, the follicle is still in the ovary, and that empty follicle is called the corpus luteum. So it's produced by the corpus luteum after ovulation under stimulation of LH, or luteinizing hormone. The major role of progesterone is that it is involved in development and maintenance of the endometrium in pregnancy. So remember, progesterone protects the pregnancy. That's your way to remember that. And then it also is going to inhibit or block uterine contractions and dilation of the cervix. So again, that would have a negative effect on the pregnancy if we had an opening in that cervix. So we want to keep everything closed. We don't want contractions because we are trying to protect that pregnancy. So there's going to be two different cycles of hormones. So they're hormonally controlled and they occur simultaneously starting at puberty. So one, we have the ovarian cycle, and then two, we have the menstrual cycle or the period. So the ovarian cycle is a monthly formation and release of a secondary oocyte, or beginnings of the egg, and the ovarian events that occur in anticipation of pregnancy. And then the menstrual cycle is going to be the repetitive changes in the endometrium that is going to cause monthly menstruation or bleeding if pregnancy does not occur. So pretty much the difference between these two is the ovarian cycle is what's happening in the ovaries every month, and then the menstrual cycle is what's happening to the endometrium or the uterine lining every month. So the female reproductive cycle, the cycle is going to range from 24 to 35 days. 28 days is going to be your textbook average menstrual cycle. The cycles are going to continue from puberty, which is usually around 11 years of age, until menopause. What menopause is when our reproductive cycles stop. So it's the cessation of reproductive cycles, and usually that happens between 45 to 55 years of age. So this picture here is just showing you the difference in these cycles. So we have the ovarian cycle on top. So you're seeing here that the follicle is developing until we get to this mature follicle, and then we have ovulation, which is the release of that egg out into the uterus, and then that corpus luteum is the empty ovarian follicle that is going to eventually degenerate, and then every month we're going to have a different egg that is developing and ready to be released. Whereas the menstrual cycle here, you can see this is talking about the endometrium, which you can see it's getting thicker throughout the month. So it's going to be thickest right before bleeding is going to occur, which would be this right here. So it's going to get thicker and thicker, and then of course this is if fertilization does not occur, then it's going to start to thin out, and that is what is shed during the menstrual cycle or the period every month. So talking a little bit more about the ovarian cycle. So again, puberty is going to begin at approximately age 11 with the first menstruation, which we often call menarche, at approximately age 13. So puberty doesn't necessarily mean that a female has gotten her period. It just means she's starting to kind of have those changes, and usually first menstruation and first bleeding is going to be around age 13. This cycle will begin when the hypothalamus secretes GnRH, which is one of your hormones from the anterior lobe. So that comes from the hypothalamus, which stimulates the anterior lobe to release FSH, or follicular stimulating hormone, and a small amount of LH, or luteinizing hormone. So right here, this is just showing you the different phases of the ovarian cycle. So we have the follicular phase is going to be before ovulation, and then luteal phase is going to be after ovulation. So during the follicular phase, again, that means before ovulation of each ovarian cycle, FSH is going to promote the development of about 20 primordial ovarian follicles to turn into primary ovarian follicles. Each of those is going to have a primary oocyte that's surrounded by follicular epithelial cells. Then some of those primary ovarian follicles will develop into secondary ovarian follicles, but we still have a primary oocyte that's been surrounded by follicular epithelial cells. So then our secondary ovarian follicles can transition into a tertiary ovarian follicle. At this point, we're getting, again, more and more mature. They still have a primary oocyte, but now they are surrounded by granulosa cells. So granulosa cells are going to secrete estrogens, and they're going to pass nutrients to that developing oocyte, so that way we are getting the best and most mature egg to be released. So one dominant tertiary ovarian follicle will continue to develop. All of the other ovarian follicles will undergo atresia, which is just death. So they will eventually just kind of disintegrate away. So that dominant tertiary ovarian follicle secretes low levels of estrogen and inhibin into the blood. So inhibin is going to have an inhibitory effect on the anterior lobe of the pituitary gland, and it's secreted by the ovaries. Why we want that is it's going to initiate a negative feedback mechanism with GnRH and FSH. So pretty much we're saying we have our dominant ovarian follicle. We don't need to develop any more right now. That process will start again the next month. So we have inhibition of FSH will prevent the development of additional ovarian follicles because we want to save that for next month. We don't want to continue to develop them right now. So due to that increased FSH sensitivity, the granulosa cells are going to increase estrogen production. This is going to begin on day 7 and peak on day 12. We're going to have high blood levels. The estrogens are going to stimulate GnRH production with a positive feedback mechanism because we have more estrogen, which is going to lead to more GnRH, which is going to lead to more LH. So GnRH is going to lead to the production of LH from the production of the pituitary gland. Then we're going to have a sharp LH increase in the blood on day 13, which is also just known as a surge of LH, and I would highlight that. So that's what you're seeing right here in this picture. This peak right here is going to be that surge of LH that signals that ovulation is coming in the next day or so. So with that rapid increase in LH, we're going to have that mature tertiary ovarian follicle that is going to take it to its final last step. So it's going to take the tertiary ovarian follicle into a mature ovarian follicle. So that's your first blank is mature. So that's going to stimulate the completion of meiosis I to form the secondary oocyte. Because remember that secondary oocyte is what's released at ovulation. And then it's going to stimulate ovulation of that secondary oocyte, which will occur about 14 days prior to the onset of next menstruation. And again, I would highlight that it occurs 14 days prior to the onset of next menstruation. So then after ovulation, we have what we call the luteal phase. That's that section right there. So LH is going to stimulate the remaining granulosa cells in the ovary to become the corpus luteum, which again is that empty follicle, and is going to secrete hormones that are going to prepare the uterus for pregnancy. So it's going to secrete progesterone and some estrogens for about 10 days after ovulation. So it's going to protect any possibility that the egg gets fertilized. And then that elevated blood progesterone level, along with a little bit of estrogens, is going to inhibit GnRH secretion. So we are inhibiting that secretion of that hormone to be released anymore. So the loss of GnRH is going to inhibit the release of LH and FSH. So we're pretty much just protecting and almost acting like the body is pregnant for this time period for about 10 days until the body kind of decides, okay, is there a fertilized egg or is there not? And that's what will decide the next steps. So if fertilization does not occur, then the corpus luteum is going to degenerate into a non-functional corpus albicans. So we're going to have a rapid decline in blood estrogens and progesterone during the last few days of the cycle. So we're going to have a loss of the negative feedback control, which will allow that GnRH to start to be secreted again. So progesterone is no longer blocking it, so now that next reproductive cycle can occur. If fertilization does occur, then that corpus luteum will enlarge. We'll have producing increasing amounts of progesterone and estrogens, and eventually that corpus luteum will degenerate by about 16 to 20 weeks of pregnancy, and then that is going to be when the placenta takes over. So this picture here just kind of reviews what's going on with these hormones during this cycle. So you can see the GnRH is being released from the hypothalamus, which is going to stimulate FSH and LH to go to the ovaries, and that's just going to review this whole process of how we have this negative feedback cycle. Inhibin right here is going back up to the pituitary, blocking any more of that hormone to be released until we know if we have a fertilized egg or not. So then going on to the menstrual cycle. So the menstrual cycle is referring to the monthly changes in the endometrium or the uterine lining with each month. So this is going to occur in response to changes in estrogen and progesterone in the blood. And we're going to have 4 phases: menstruation, proliferative phase, secretory phase, and premenstrual phase. So this right here is just showing the different phases. So we're looking down now at the menstrual cycle. So we have menstruation, proliferative, ovulation, which is not technically one of the phases, but that's just showing you when ovulation is occurring, secretory, and then premenstrual. So now we're looking down here. This chart calls it the uterine cycle. So this is what we're talking about. So menstruation is going to begin on the first day and lead up to 3 to 5 days. And during this time, FSH is increasing. And I would write that down. So during menstruation, FSH is increasing. Your proliferative phase, so this is going to be characterized by a buildup of the endometrium, so it's starting to get thicker and thicker. It's stimulated by estrogens that are produced by the developing ovarian follicles, and this is going to begin at the end of menstruation, and then it's going to end at ovulation. So the secretory phase, this is what begins at ovulation, is going to last about 10 days. It's controlled by hormones from the corpus luteum. So it's going to have estrogens that continue to stimulate endometrial thickening. It's going to have progesterones that stimulate the formation of blood vessels and glands in the endometrium. And then it's going to just help prepare that endometrium for a pre-embryo. So pretty much we are just thickening this lining and getting it ready. It's going to be nice and cushiony for that baby to implant and get ready to develop. And I would highlight this last section on this slide right here about the hormones of the corpus luteum. And then we have the premenstrual phase. So this is going to occur during the last few days of the cycle if fertilization does not occur. So this is when we have the breakdown of the endometrium. It's going to be due to a rapid decrease in blood levels of estrogen and progesterone. And this is going to lead to menstruation or vaginal bleeding, which is going to be the start of a new cycle. So again, this is just kind of showing what's happening. This is going from one ovulation to the next ovulation. So we have menstrual in the middle, the menstrual cycle. So it's really thick right before you have menstruation. Then during this time is when you are shedding that lining. So that's when you're bleeding as you're breaking down that lining. And then post-menstrual is it's going to start to build back up and get ready for ovulation again. So now we're going to watch a quick video about the ovulation and menstrual cycle.
The female reproductive system is made up of different parts, which includes the uterus, endometrium, fallopian tubes, and ovaries. During the menstruation cycle, each of these parts has a specific function. For example, inside each ovary, there are thousands of follicles, which are cells with an immature egg. The egg is the female reproductive cell, preparing for ovulation. At the start of your cycle, the follicle-stimulating hormone stimulates a large number of follicles. As the follicles get stimulated, the immature egg inside them begins to grow, mature, and also produce estrogen. Estrogens then go into the bloodstream and send the signal to prepare the uterus for pregnancy. At this time, the endometrium, which is the inner part of the uterus, is covered with a thick and spongy layer. Day 7. The dominant ovum produces a large amount of estrogen that travels directly to the brain and activates the pituitary gland, which is responsible for producing large amounts of hormones, including luteinizing hormone, which stimulates ovulation. Day 14. The luteinizing hormone begins to act on the ovaries, causing the dominant egg to mature rapidly and detach from the follicle. Now one of the fallopian tubes surrounds the follicle, causing it to open completely and expel the egg. This is known as ovulation. At the end of the fallopian tube is the fimbria, a set of cells that are responsible for collecting the recently expelled egg and transporting it to the entrance of the fallopian tube. Once here, by means of muscular contractions, the ovum is pushed towards the center of the uterus. Day 15. Starting on day 15, progesterone is produced inside the ovary, which is the hormone that helps the second phase of the menstrual cycle to occur. These days, the abundance of progesterone can make you feel more active and productive, and you'll also notice an egg white-like vaginal discharge being released. At the same time, you'll feel a greater desire to be with your partner. Towards the end of the cycle, the production of progesterone decreases drastically, and that is when the so-called premenstrual syndrome occurs, which can cause various symptoms such as mood swings, inflammation, pimples, fluid retention, colic, pain, and sensitivity in the chest, among other emotional and physical symptoms. Day 28. This day, the menstrual cycle is completed. Your body is about to menstruate. Day 1. It is the first day of menstrual bleeding, through small contractions that we know as menstrual cramps. The ovule and the thick and spongy layer that had formed in the endometrium are discarded in the form of menstruation. And so the whole cycle begins again. This is the typical 28-day menstrual cycle. However, cycle length can vary from woman to woman. Menstruation is a natural process that represents the amazing capacity and strength of a woman. So if you also know a woman that you feel proud of or feel...
All right, so next up we have menopause. So menopause is the cessation of regular menstrual cycles, usually begins around ages 45 to 55 and can last up to 10 years. So the onset is usually gradual and menstrual cycles become irregular. So this is caused by the aging of the ovaries. So you have fewer primary ovarian follicles that exist to respond to FSH and LH. So at this point, you're having no ovulation, and then the secretion of your hormones, such as estrogens and progesterones, is going to be curtailed or start to decrease because you're not having that ovulation. So menopause is considered complete after 1 year of no cycles. Some of the symptoms of menopause includes headaches, insomnia, so the inability to sleep, depression, and hot flashes. And we can use hormone replacement therapy. Sometimes you'll hear it called HRT in order to treat symptoms. Unfortunately, though, some of the risks with HRT and giving synthetic hormones can also be that we are increasing the risk of breast cancer, strokes, as well as heart disease. So this last slide here is just showing you some of the different types of hormone replacement therapy. So one of the ones that's really popular right now is what we call pellets. So over here on the left, you see what that pellet looks like and how it's inserted on the bottom. So it's inserted with a little needle, little insertion is made, or incision is made, and then you put the needle in, you push the pellet through, and it's unique to each person, kind of what hormones you're going to get based off of what you're lacking. And that lacking of hormones is what's causing the menopause symptoms. So most people get hormone replacement therapy due to the symptoms because they are just interfering with their daily life, just being super fatigued, having really bad headaches, hot flashes, things like that. So that is a lot of the time why people seek out hormone replacement therapy. And then over on the right, there's some other different types. So you can also have oral HRT, vaginal, and transdermal. So these are all just some examples of HRT, but like I said, it does definitely come with its risks, so it's definitely something that each individual person needs to consult with their doctor about. So that concludes our lecture for today.